You improve your French, in fact. Good morning, everybody. It's not an easy task to deal with the drugs. Are they efficient in treatment of varicose vein? That is a question. As I am the first speaker, I want to remind you what is the definition of varicose vein. They are defined by subcutaneous dilated veins, 3 millimeters in diameter or larger, measured in upright position and usually tortuous. Distinct, so they must be distinctive from reticular vein by a diameter of 3 millimeters or more. What are the symptoms with varicose vein? You have the list, you can read them. Some of them are really more associated with varicose veins than the other. For example, I am not really sure that restless legs and leg tiredness and fatigue, okay, thank you, are related to varicose vein. What about the pathophysiology? In varicose vein, you have reflux in the superficial venous system. That leads to capillary stasis, and capillary stasis is responsible of cellular and molecular effects. We will see that in detail. When there is no capillary stasis, there is no adhesion of white cell. When you have a capillary stasis, as it has been said by Andrew Nicolaides before, there is activation and adhesion of white cells. Leukocyte adhesion and activation related to capillary stasis initiate cellular infiltration and protease production. And you have an increase of cytokine and abnormal synthesis of protease. That is the pathophysiology of primary. The other part is venous valve and vein wall remodeling. You can see that adhesion of white cells on the valve and on the wall of the vein. And when it happens, you can identify them by B-flow. The second is there is a mixture of hypertrophy and atrophic segment. We know why there is an hypertrophy. You know, you can read it. It many factors, but we don't know exactly why there are sometimes in some parts of the vein you have dilated and non-dilated part of the vein. We don't know why. So it leads to varicose vein. Very obvious. Macromolecular leakage leads to edema. Microhemorrhage leads to trophic change as hyperpigmentation, as you can see here. That is the detail of pathophysiology. And lymphatic are involved. When the lymphatic cannot cope with the edema, you know, again, there is another kind of edema. It's a pitting edema, which is characteristic of lymphedema. Well, so what is the mode of action of venoactive drugs? They act in 4 compartments. First, the venous tone, that is the 3rd column. It works on the capillary network by reducing hyperpermeability by inhibiting the leukocyte endothelium interaction. It works on the lymphatic network by increasing functional lymphatics. And the last one is on the venous valve, valve protection by inhibition of leukocyte endothelium interaction. So 4 in total. That are all the articles. There are many studies, you know. In the 2nd column, you have the venoactive drug. In the 3rd, 4th, and 5th, you have the what is the action on venous tone, on capillary network again, on lymphatic network, and on venous valve. So many studies. About pain, that has been clearly explained by Andrew Nicolaides again, where patients are symptomatic. The main symptom is pain. Why? Because there is a capillary stresses, so you have a diminution of the shear stress and augmentation of hypoxia. So that is leukocyte endothelium dependent inflammation. And it can work on venous valve, on wall remodeling, on extravasation of activated white cells in capillaries, and also in skin by augmentation of protease and cytokines. And in all cases, you have an activation of the C fibers of skin, of surrounding capillaries, or on the venous wall that is responsible of pain. That is very simple. We discovered that recently, I would say. And we know that some venoactive drugs, such as MPFF, works because they reduce the inflammation. The leukocyte endothelium, that is the hamster model. Okay, good, thank you. That is 60 minutes after ischemia, treated by placebo, and when you move, you add I think it's MPPF, you can see the acceleration, 60 minutes after ischemia reperfusion, the speed is higher. Thank you. So if you look at the Cochrane review, what are the action of the venoactive drugs? In the Cochrane reviews, that is Martinez and Peters, the reference, all active drugs they lead to edema reduction, restless legs, and trophic disorder. And you can see that there are different actions concerning MPFF, retosid, calcium, the benzoate, and horse chestnut and C extracts. So we have, according to the Cochrane review, different actions are related to the venoactive drug. Probably all of you know the GRIAD classification, which is a grade of recommendation and quality of evidence. One is strong, second is weak, and quality of evidence can be applied to number one and number two. That is very important. We use this tool now in order to make recommendation about investigation, about treatment that is used everywhere in the world. So, what is the place of venoactive drugs according to this grade of recommendation? That was written by Coleridge Smith in the Handbook of Venous Disorder, the last edition, that was 3 years ago. Symptoms are known or associated with signs such as varicose vein. That is a grade 2B, which is a weak recommendation. Concerning the long-standing leg ulcer that was formulated by Coleridge Smith, the grade is better, is grade 1B, but in association, of course, with compression or surgery, not alone. That is very important to know. And we wrote an article that was published in the European Journal of Endovascular Surgery, and we made tentative recommendation for venoactive drugs according to the graded system, and you can read the grade of recommendation for MPFF, retins, calcium benzoate, horse chestnut, and ruscus extract. Now I will try to give you some indication for venoactive drugs in varicose vein. The first group is C2S patients. They are reluctant to undergo operative treatment or to wear all their life a compression ovular. In this case, I think it's a good indication for venoactive drugs. If it works, it's okay. Patients are happy. The second one is for women who wish future pregnancy. You probably know the very good study made by Fisher. It was published in the Journal of Vascular Surgery in 2006. And the findings suggest that you have to counsel women about the effect of future pregnancy that is present, especially in ancillary surgery, because you have a lot of recurrence. And also it's true for obese or mainly previously Perris patients. In C2 plus patient, that is something new. What is C2? It's a patient combining varices and something else. Edema, trophic change, ulcer. That is, of course, not the first intention treatment, but it can be used in combination with compression, with any kind of surgery. But you have not to treat the patient with that. Okay? And the guideline for testing drugs in CVD, of course, we need randomized controlled trial. We must use the advanced CIP classification, have a consensus on endpoints, and the extension of the new grad system for future guidelines. Thank you very much.